This afternoon is the memorial lecture, and we'll have Dr. Warrens come up in a minute, but first, it has been our tradition, I guess, for the last previous 11 years, that we typically started out having one of the doctors that cared for Max giving a little introduction for the memorial lecture. And I know Tony has done it before, and Dr. Hordoff and Dr. Summer. And then many of Max's friends started coming to this great day and being here with Rena and Tony. And we've had Heather and Alex and Matthias all give talks and tell their story about Max, which is really wonderful. And I know on the back of our program is Max's story. Our guest speaker today, one of Max's friends, was a friend in middle school. So he didn't get to experience Max as a college and young adult when he was doing magic tricks at the learning from magicians at the Robbin deli, or being an accomplished chef and feeding his friends. And Max, not unlike his parents, who are both in the arts, became really a fantastic photographer, and was really interested in taking magnificent pictures. And he just was a fantastic Renaissance guy, right? He really was. So you can learn more about Max's life on the back. I'm not going to read this because I want to give some time for Dr. Jonathan Menachem to come up and tell his story about how he knows Max and how Max has affected his life and career. So without further ado, Jonathan, please come up. Thanks.
Well, thanks for having me. So I would start by telling you about the first time I remember meeting Max. I grew up in Manhattan, I went to Dalton, and I was part of the downtown bus, which is sort of an unknown entity at Dalton. Everyone's from the Upper East Side, so that we had the one blue bus, and I got on the bus, and I looked at Max, and I thought to myself, finally, there is somebody who is not taller than me. So Max was not the tallest guy, and then he started talking, and then the next thought I had was, oh my God, he's so much smarter than I am. This kid, he probably had like a 30-year-old's vocabulary at age 12. So he was definitely older beyond his years, and I think people have said that before about him. He was talking about eating sushi and cooking sushi when we were in middle school, which wasn't a thing then. Like, he was on the forefront in New York City. What did we know about Max as kids? And the truth is, we knew very little about him. We knew that he had a scar, and he told us that he had had heart surgery. I guess now looking back, you realize what all he had undergone. At that time, we just thought it was, it's just a fairly standard heart surgery, and it's probably more dangerous that he's sitting in the front seat of a van in New York City with no seatbelt. But we knew that he got to ride the elevator, never had to walk up the 8 flights of stairs to go to class every day like we did in New York. But other than that, we didn't really know very much, and it was interesting because Max and I weren't in the same grade. He was a year above me, so I knew him from the bus. And in talking to his parents last night, you realize that he had some struggles growing up as a kid with heart disease. On the bus, we didn't really see it because, we didn't play sports on the bus, and it was just all about talking about the Yankees. And so I never realized how probably he did struggle with some of the ideas and the difficulties of growing up as a child with heart disease. And so, I moved away to North Carolina, and then years went by, and I used to think about Max, and then once I went to medical school and knew I was going to do something with congenital heart disease, and I always used to think about, I wonder what he had and what happened to him. And then it's not easy to find a person named Max in New York City with congenital heart disease, no matter what sort of combinations you put together on Google. And then recently, my parents moved to Nashville and had all my old yearbooks, and I was able to find, Max's last name, and that's how I wound up here. And I'm definitely sad to the fact that I didn't get to reconnect with him before he passed away. Hearing the stories and seeing sort of what he did is incredible as a Fontaine in the era that he was. So right now, what am I doing now is I'm focused on I'm in the transplant group at Vanderbilt, where I have done, in fellowship, I did a combined congenital heart and transplant fellowship at Penn. And now my focus within the world of transplant is focusing on failing congenital patients and how we get more of them to transplant. And clearly it's a needed area, but growing, and I'm not sure we know all that there is to know. It's interesting that when I talked to his parents last night, oftentimes when I go in the room and mention to patients that we're going to talk about transplant, there's often tears and sometimes just blank stares, like what the heck's going on. It's interesting to hear about how Max actually interviewed his doctors and would sit and I could sort of see that, like having remembered what Max was like, is that and it would be kind of nice to have a patient come in there and just grill me and ask me all the questions and actually probably know as much as I do. But, that's something that hopefully over time we start to improve upon, and that patients become more active in asking us questions and getting involved. And so I just want to thank you guys for the opportunity. I think this is an amazing day, that the ability for everyone to interact and learn about all these amazing cases and learn from the giants in the field. I mean, it's quite something. So I'm honored and humbled to be here. And so now we'll turn it over to Dr. Warrens. Thank you.
Thank you so much, Jonathan. It's just wonderful. Okay, and now we're on for our second lecture of the day, the Memorial Max Robbin Lecture, which Dr. Warrens will now give.
Thank you very much. If I could have my slides up, please. I want to just underscore how honored I am to be here on this special day, and what a privilege it is to be here. And I've called this talk Adult Congenital Heart Disease, the Courage to be Imperfect. What do I mean by that? This was a sign that was on the bathroom door on the Paul Wood ward in the National Heart Hospital, put there by Jane Somerville. It was an expression that she used a lot, but never knew the origin, and the sign was very large, and it was actually a statement used by a psychiatrist back in 1925 at a congress in Berlin. And it was written about by this Austrian psychiatrist, Dreikurs, about whom this book was written. And so this is what he wrote. To be human does not mean to be right, does not mean to be perfect. To be human means to be useful, to make contributions, not for oneself, but for others, to take what there is and to make the best of it. If we can't make peace with ourselves as we are, we will never make peace with ourselves. This requires the courage to be imperfect. And later it was written, the willingness to be wrong, or more properly, the courage to be imperfect, allows us the opportunity to discover many things about ourselves. Getting it right and avoiding the faux pas derails our momentum and deflects our potential evolution. So, how do we relate this to adult congenital heart disease? As I mentioned this morning, there are certainly more than 1 million adults in North America, with a population that is growing quite rapidly. And so how does this relate to the courage to be imperfect? The Oxford Dictionary defines courage as the quality of mind or spirit that enables a person to face danger, fear, or difficulty with self-possession, confidence, a resolution, bravery. And imperfect is to be faulty or incomplete. So I thought what I would do is look at the field of adult congenital heart disease from the perspective of surgeons, from cardiologists, and last but most importantly, the patients and their families. What does it mean to have this courage to be imperfect? John Kennedy said, "You can't know where you're going until you know where you've been." So I'm going to begin with a little history of congenital heart disease. I'll remind you that Robert Gross first repaired a patent ductus as far back as 1938, and Clarence Crawford first resected a coarctation of the aorta back in the 1940s. But of course, these were operations outside the heart. Here's a picture of Al Blaylock performing that first Blaylock-Taussig shunt, a dramatic change in the lives of blue babies. But operating on the heart itself was a different question. Many years ago, a famous surgeon said, "A surgeon who tries to suture a heart wound deserves to lose the esteem of his colleagues." How could you open the heart and circulate blood to the brain? Could you cool? Could you oxygenate in some way? These were the challenges that these early surgeons were faced with. How could you possibly open the heart itself? And to go back, as we look at some of the history, this was William Mustard in Toronto. I'd remind you he was an orthopedic surgeon, tried to operate on the heart. And in 1951, he operated on a 16-month-old with tetralogy of Fallot. And his idea of oxygenation was this contraption here. He used 4 monkey lungs in bell jars into which oxygen was forced. This was his bypass machine. Needless to say, the patient died on the table. By 1954, he'd operated on 12 children. All of them had died. Courage on the part of the surgeon and the patients and their families. So this was obviously a disaster, but in Minnesota, where I am, there was huge and fierce competition among the surgeons. So Minneapolis in the north at the university, and about 90 miles south in Rochester, where Mayo Clinic is, there were 2 surgeons who were fighting fast and furiously to be the first to operate on the heart. F. John Lewis, in 1952, first used hypothermia. He operated on a 5-year-old child, cooled to 81 degrees, put tourniquets on the veins to have a semi-bloodless field. He closed the atrial septal defect in 5.5 minutes and operated on 20 patients using this technique, warming them up in a bath that was bought from Sears, incidentally. He operated on 20 such patients using hypothermia in the early 1950s. And that was the beginning. And the physiologist John Gibbon was developing the first heart-lung bypass system, and he used it in 1953 to close an ASD in an 18-year-old. But he lost his next 2 patients, didn't have the courage to continue, and so he gave up. And then in Minneapolis, there was this family, the Glidden family, and little baby Gregory, who was 13 months old, you see there in the middle. He was born with a hole in his heart, a ventricular septal defect, and his sister LaDonna, the eldest one in this picture, had also had a VSD, and she had died when she was 12. So the Glidden family approached Walt Lillihei, the surgeon there, and he performed the first cross-circulation in 1954. The baby is in the forefield, and the father, who was used as the oxygenator, is further away with his anesthesia team. Here is the father with baby Gregory in 1954. And this was the first cross-circulation where the human, the parent, was used as the bypass system. Gregory was connected via cross-circulation. The VSD was closed by Lily High. There was 19 minutes on this pump. Since it was in Minnesota, this was a pump designed to move milk, and it was connected by beer hose. Very innovative. Baby Gregory woke, began to drink and eat over the next few days. It was thought a success, but he succumbed to pneumonia 11 days later. About a month later, Bradley Merman, remember that name, he'll come up again, was the first survivor, 3 years old, connected to his father, 24 minutes open heart time, and he survived, the very first survivor from Lily High. Lily High didn't think Bradley Merman was quite photogenic enough to advertise to the press, so his second patient, who was very cute and pretty, as you see here, also connected to the parent, looks very happy and fit 7 weeks after her open heart surgery. But she was the second, not really the first, but certainly very cute, and Bradley Merman survived. By autumn 1954, Lily High had lost another 6 of his 7 patients, including a 7-month-old baby, and they died with all the complications you might expect: infection, heart block, no pacemakers back then. So losing most of the patients, including stroking one of the parents. But by 1954, that same year, just a few months later, he went to way more complicated things than VSDs and repaired the first tetralogy of Fallot, again using this cross-circulation with a parent. So things were beginning to move apace. And at Mayo, our surgeon John Kirklin worked with the Gibbon machine and developed this Mayo Gibbon machine. It's now in the Smithsonian. This was the very first mechanical device that was used for bypass intracardiac repair. This was in 1955. And from then, of course, surgery was beginning. But he, too, lost 4 of his first 8 cases. Imagine having surgery with a 50% mortality. But then it began, this surgical explosion for these complex heart diseases, the Senning operation for transposition, Donald Ross repairing pulmonary atresia with an aortic homograft, the Fontan operation, about which we know much, the switch operation, and at Mayo repairing Epstein patients. Of course, this is a real innovation and an explosion and a great triumph for these surgeons. And so if you look back 60 years ago, when 25% of newborns with congenital heart disease died in their first year of life, 60% died in the first year, only 15% survived beyond puberty. So if you reflect on the surgery, anesthesia, intensive care, echo that we can make a diagnosis in utero at 18 weeks, you can see why we have this so-called new community, not really so new, of adults with congenital heart disease. This is a triumph of a story that's happened over the last 60 years. But despite these surgical triumphs and the courage it took for the surgeons, considerable challenges remain. Why is that? Inadequate surgery, not because the surgeon is inadequate, but maybe they leave a minor lesion that inevitably progresses. Anything that's left an abnormal valve will get thicker and stiffer with time. Patients get infected, endocarditis. Any valve replacement or conduit degenerates. Any abnormal valve will calcify as patients get older. And then there are those patients who need a radical repair after they've been palliated with surgical shunts, such as the Blalock-Taussig. So the story isn't necessarily over. I mentioned prosthetic valves. Of course, they ultimately wear out. They only last on average for 10 or 15 years. They may get thrombus or infection. And any time you use a conduit with a valve, they too, like this one, fur up when it's lined by fibrin and this peel, and they become obstructed. And then the patient needs another operation. I've been blessed in my career to work with some fantastic surgeons. Donald Ross, I was with for 5 years of my life, Magdi Yacoub, and then at Mayo, Gordon Danielson, and more recently, Joe Deraney. They have taught me much. But remember Bradley Merman, that very first survivor I mentioned. He became my patient about 15 years ago. And here's his chest x-ray. Huge right side of his heart. He's in atrial fibrillation. We talk about physical exam, and you walk into the room and he has V waves wagging his ears. He's very short of breath, and you straight away can say, before you do anything else, I know what's the matter with you. And he says, you do? Nobody else can. And of course, what happened was, after that first surgery that Lily High did, the VSD wasn't closed properly, and at age 12, Bradley went back for a second operation to reclose the VSD. But, like the patient this morning, the septal leaflet of the tricuspid valve was stitched into the VSD patch. And so now he has severe tricuspid regurgitation. You can make the diagnosis on the end of the bed. And so now he's facing operation number 3, way too late, when his right ventricle is huge and dysfunctional. But that is what he had, and he survived until actually about 2 years ago. And as we think about courage, this was some data from Mayo looking at the period of time from 2010 to 2015, looking at the operations that patients are having. So sure, most operations are number 1, but look at the number of patients having operation 2, 3, 4, 5, 6. In fact, this slide is way out of date because we have 2 patients who've survived 10 cardiac procedures and are still alive. Our mortality for all of that is less than 5%. It's extraordinary what we can do in the current decades with great care. But think about that. Patients, those of you that have had one patient going for cardiac surgery, think what it requires to be operating on a patient for a 3rd or a 5th time. And this, of course, is one of the major concerns, the redo sternotomy, when you've got a calcified conduit immediately behind the sternum. The sternum is cut into, sawed into, so can the conduit. And here's a patient again facing operation number 4 with a narrowed conduit immediately behind the sternum and in danger of being cut into. This requires experienced surgery and very special care and courage on the part of the patient and the surgeon. Here's one I saw fairly recently. 3 prior conduits. You can see again it's immediately behind the sternum. It's markedly calcified. Now this patient's facing the 4th sternotomy, but survived. So the surgeons certainly require enormous courage. I like this quote: to remain indifferent to the challenges we face is indefensible. If the goal is noble, whether or not it's realized in our lifetime is largely irrelevant. What we must do, therefore, is to strive and persevere and never give up, which surely is what the surgeons have done. Let's turn our attention to the cardiologists, the general cardiologists and the subspecialists like some of us in this room. Let's focus on the general cardiologists. They, too, have to have courage to be imperfect. They have little or no training in adult congenital heart disease. They don't know the anatomy. They don't know pathophysiology or the treatments. They have to recognize, as we talked about today, that they have lack of knowledge. And they need to have wherewithal and courage to ask for help and refer when necessary. And they really are unfamiliar with the challenges of patients who may have been unoperated, the rhythm problems, the infection, pulmonary vascular disease, ventricular dysfunction. And one of the major problems is late referral for these patients when ventricular dysfunction, as I touched upon briefly this morning, has already occurred. They refer patients when it's way too late. Observe due measure for right timing in all things, the most important factor. Now look at this. This was a patient of mine seen in a distinguished adult congenital heart disease center, and I was asked to look at her echo. A 62-year-old woman, I don't think the heart size gets much bigger than this. She had a murmur as a child and was seen by the great Helen Taussig, who said, "Never let anyone operate on you." And everybody took that very seriously because it was Helen Taussig. And you can guess the diagnosis. This is Ebstein's anomaly. But in 2002, she has atrial fibrillation, heart failure, ascites, and in 2010 requires a pacemaker, and now is in terrible heart failure. And I said to the group who sent me the echo, "Please send the patient, let me have a look." She weighed about 85 pounds, had cardiac cachexia, had a JVP up to the ears, severe tricuspid regurgitation. Her liver was very enlarged and pulsatile, and on a 6-minute walk, she could only do 450 meters. Here's her echocardiogram, and you can see this little left ventricle at the bottom, and look at this huge right ventricle at the top. And in the apex down format, you can see the tricuspid valve waving at each other and torrential tricuspid regurgitation. Never let anyone operate on you. But we did. We replaced her tricuspid valve with a bioprosthesis, did a right reduction atrioplasty. A year later, on the treadmill, she does 114%. Now she does 124%. She walks 8 miles every day, and she's flying around the world and says to our surgeon, Joe Deraney, "You changed my life." But we were lucky. Not only the skill of the surgeon, but a lot of luck. Because this is the problem in these patients with Ebstein's. They will do so much better if they're referred when they're class 1 or 2, compared to a survival when they're functional class 3 or 4. She should have been referred 20 years ago, but now she's referred with cardiac cachexia, but happily we were able to bring her through. Our surgical mortality for this lesion now is less than 2%, but we know that if you refer these patients late, when the right ventricle is more than moderately decreased in its function, the hazard ratio of surgery approaches 3. So they need to be referred early to surgery before ventricular dysfunction occurs. Don't wait. So general cardiologists also need to know about operated patients. What are the problems these patients face? Again, rhythms, infection, pulmonary vascular disease, and these challenges I mentioned of reoperation, and not referring patients after surgery also when ventricular dysfunction has occurred. This is a patient who lives in Alaska, a 38-year-old man who has repaired tetralogy of Fallot, and this is what his doctor wrote in the patient's chart. Unfortunately, he was fixated on the right ventricular enlargement and decreased function. I tried to explain it's reassuring. He hasn't developed pulmonary hypertension, and the right ventricle can continue to function fairly well, as it doesn't have to generate significantly high pressure, but still, he's not feeling well. If he continues to have decreased RV function, he may progress ultimately to needing support with an RV assist device and potentially even a transplant. So now the patient read his own notes, read a transplant. He had no idea. He knew he wasn't feeling well. He knew his right ventricle was big on his echo because he looks at all his reports, and he referred himself to Mayo Clinic. And here is his echocardiogram, and I just show you the right ventricular outflow, and you can all tell that this is severe pulmonary regurgitation, as you noted this morning, completely overlooked by his physician and by echocardiography. And they're writing maybe this patient will need a transplant, and of course what he needs is a pulmonary valve replacement, and of course he's at risk of VT and sudden death as we replace these pulmonary valves late, and we need to replace them before they get right ventricular dysfunction. But his own provider didn't know that and missed the diagnosis. What about the subspecialists, those of us in the room? Do we need courage for anything, individually or collectively as a profession? I would suggest to you that we need that also. How and where do people train? Do you do adult cardiology? Do you do pediatric cardiology? Do you do med-peds? There are a few centers around the country, indeed around the world. And how long are you expected to train? This is a long pathway. The length of training, are you willing to do that? The length of training is a mandatory 2 years for congenital heart disease. I trained for 5 years in adult congenital heart disease after the rest of it, but nobody's willing to do that nowadays. And at the end of it all, there's no job security. And how do you get a job? And how do you generate revenue when you go somewhere? Thousands of congenital heart patients don't suddenly knock at your door and say, I want to be seen. And how do you bridge that gap between adult and pediatric cardiology? We talked about the importance of transition, especially when they're not in the same building. Who has privileges in what hospital? And how do you navigate those difficult things? We, too, have to have courage to overcome these obstacles. What about my experience? Well, here is one of the hospitals where I train, the National Heart Hospital in London. And here is me in the middle, probably unrecognizable back in the dark ages, sitting with a couple of patients. But I too had to have some courage. A consultant cardiologist, a man in that hospital, said, I will never work with a woman senior registrar. And I was told, you will never get a job in adult congenital heart disease. So it wasn't exactly straightforward for me either. But I met this person, some of you know, especially Max's parents. She's been here before, Jane Somerville, and she certainly inspired me to change the course of my cardiology career. You cannot swim for new horizons unless you have courage to lose sight of the shore. And I had to lose sight of the shore, and so I went to Rochester, Minnesota. That was my journey in 1987, where I didn't know a soul. And so I went to Mayo Clinic, where there were 59 male adult cardiologists and me. I have to say they were welcoming. And I had some good mentors, Jamil Tajik, Jim Seward in imaging, and Bob Fry, who was head of cardiology, who were really great mentors to me. I was talking to fellows about mentorship. But it certainly wasn't easy. And my job was to bring together adult cardiology and pediatric cardiology and try and have people work together and collaborate. It took me 26 committees to be able to put a stamp in the then handwritten notes that I had an adult congenital heart disease clinic. And 26 committees took some battling, let me tell you. It wasn't all universally accepted that we should have a congenital heart disease clinic. But of course, we need people on this team. We need trained people, we need specialists, and we need ACHD surgeons, and we all need to work together. Jane used to teach, to understand frogs, you must know tadpoles, and to understand tadpoles, you must know frogs. Meaning, if you do adult congenital heart disease, you should know some pediatric cardiology. And pediatric cardiologists needs to know what happens to their patients as they grow up and become adults. So I like this picture of this rather lecherous-looking frog, but you understand the meaning. So we need to understand each other's disciplines. We need to know how the anomalies develop and change, and we need to work together and collaborate and be happy and successful. And when you try and set up a clinic, that requires some battling too. You have to have institutional commitment, support from administration, finance support. Is there training? Is there collaboration between the teams? Interdisciplinary care teams? Facilities for in-hospital care. You've got to have somewhere where the patients can be admitted. How do you have easy access for referral? One telephone number should be the way that patients get to you. It's a huge resource-intensive time commitment that's not won easily. Everything is imperfect in the beginning. Doesn't happen overnight. It takes time and commitment to build and develop a program, as many of you will discover. And so you go from bricks and mortar, and if you're lucky, you end up with a big building. But is everything perfect? I don't want to pretend that it is. Absolutely not. It's not bad, but it's not perfect. And I think this is meaningful to me, of this physician who took pictures of these books and talked about life's meaning in the face of mortality. It's become increasingly clear that my patients and I are ultimately trying to achieve a shared understanding of life's meaning and how to square its preservation with a sense of being mortal. And that's what we're all about. This is a photo that somebody sneaked into my office and took a photo of on my bulletin board, and this happily is some of the patients and their families and their babies that I've been involved with over the last 30 years. I've learned a lot, and it has been a fantastic journey, I have to say. But again, it's not perfect. It's a huge time commitment, as many of you know, and patients need our help, and so do the physicians, and they want answers to questions. Insurance obstacles. Here's an example. A Fontan patient who has dyspnea and abnormal liver function tests. She can come to Mayo Clinic and she'd have me examine her, but by her insurance, I'm not allowed to do any imaging. Will I please write letters to the insurance company? How stupid is that? I can't do it by divine intervention, but I have to spend hours arguing with an insurance company to be able to image her Fontan. Please write letters for me, which of course we do. Employer issues. Write letters regarding weight restrictions, shift restrictions, FMLA forms. And please fill out forms so I can claim disability, drive the school bus, take my Boy Scout troop camping. All of these things we have to do to support the patients, and we have little time to do it, but this is what we do. This is the notes on one single patient. There's no referral letter, not even a single paragraph. Dear Carol, will you please? And I have to go through 600 pages of stuff to figure out what this patient has. This is very common, as many as you know. And we have to develop trust with colleagues, referring physicians, and our patients particularly. But I would share with you a bit naughtily that there is a dark side. The telephone. I get a 10 p.m. call at night time from a 38-year-old patient with tetralogy of Fallot. 10 p.m. Do you think it's okay if I have another baby? Why are you calling me now? Because this is a really good time for me. All the kids are asleep. So I say, yeah, so was I. But we still answer the phone. And they come at you on your email over the computer. And this is an email I'd share with you from a 60-year-old patient with Epstein's. I've been diagnosed with Peyronie's disease. Dr. X is going to give me injections to straighten my penis. I wanted to ask you, what do you think? Now, of course, you'd ask your cardiologist about this, right? But this is what they do. This is the trust that we engender, and they want to know everything about everything, including their Peyronie's disease. So we have to be mindful of that. So I've talked about the individual challenges, and then there's the challenges we face collectively as a profession. And the courage to examine our practice and to recognize our mistakes and to foster quality improvement and to have reflection and analysis about the things that we do. William Heberden said, new medicines and new methods of cure always work miracles for a while. And if we look at some of the things that we've done over the years, we have to reflect. We have practice guidelines, but for most congenital heart patients, We're dealing with single-center studies with small numbers, and we certainly have our therapeutic challenges, not just in medical care. Look at the heart failure trials for acquired heart disease. There are so many of them dealing with thousands of patients that you know how to deal with heart failure in acquired heart disease. But it's completely different in congenital heart disease. We have such a wide variety of heterogeneous anatomy. It's like the animal kingdom, and we can't treat all of our patients the same when they get heart failure, including, as I mentioned this morning, for a systemic right ventricle. Yes, we have therapies we can use for the regular population, ACE inhibitors, ARBs, and so on. We can do CRT therapy, but for most of our patients, particularly those with a systemic ventricle, they just don't work. So we need to reflect on what therapeutic strategies we're using or not using, and how can we improve the fate of these patients with congenital heart disease and failure. I touched this morning on Eisenmenger syndrome and the thought that initially a high hemoglobin causes a stroke and you mustn't phlebotomize them, as we talked about, and avoiding iron deficiency. Here's another bloodletting going on, as it was in the 15th and 16th century. And yet look at this patient. Surely there's a lesson here for this echocardiogram in this person with Eisenmenger syndrome who has a double inlet left ventricle. This ventricular function looks very good. This patient's doing very well. She has this complex heart disease, and she's 70 years old, and she's still working 40 hours a week. Fantastic. Some of these patients have lessons they can teach us. How is she doing so well? So we need to be thinking about our reflection and analysis in our medical care, and sometimes unanticipated consequences of what we do, like patient selection for surgery. We talked about Fontan and the importance of that as it relates to this lecture. And initially, these commandments, these 10 commandments, as they've been called, for selecting our patients for the Fontan operation. Originally, you were supposed to obey all of these and not do Fontan unless all of these rules were carefully followed. But at Mayo, where we've done now over 1,200 Fontans, we learned fairly early from our pediatric colleagues that if you flout those rules and you violate them and your risk score goes up, we notice that the survival is significantly worse than if you're perfectly selected for the Fontan operation with a risk score of 1 or 0. We flout more of the rules, we can get them through surgery, but the long-term outcomes, unfortunately, are not as good. And so these are the unanticipated consequences of these Fontan operations. Who would have thought a decade ago that Fontan patients would get cirrhosis of the liver? We didn't know that, even though we've been doing the operation since the 70s. And who would have thought that these patients would get carcinoma of the liver? 28 patients with hepatocellular carcinoma at a mean age of 29. The youngest now is 12 years of age with liver cancer. Half of them are asymptomatic at the time of diagnosis. More than a third are picked up on routine liver screening, and 40% had metastases at the time of diagnosis. 54% died 1 year after the diagnosis was made. We never would have considered this 20, 30, 40 years ago, and now we know this is a potential complication, completely unanticipated with this physiology. So we need the courage as subspecialists to identify, reflect, and analyze our past mistakes. We need to collaborate and have multi-center studies so that we learn more moving forwards. When you do what you love, the seemingly impossible becomes simply challenging. The laborious becomes purposeful resistance. The difficult loses its edge and is trampled by your progress. Hopefully, that'll be true in the next decade. Last but not least, the patients, who surely have the most courage of all. Unfortunately, the vast majority out there remain unaware, uninformed, and uneducated. Take this example of transposition with the mustard operation that you're familiar with, where these blue babies are turned from blue to pink, but the right ventricle is the systemic ventricle, and they are vulnerable to failure. This too is an operation that the surgeons called total correction. Is it total correction? There is no total correction in congenital heart surgery, except perhaps the successful ligation and division of a patent ductus. And again, I underscore this because patients don't know their anomaly if they think they're corrected. They think they're cured, and they don't seek cardiac care. And again, these patients face problems of heart failure, arrhythmias, infection, pulmonary vascular disease, and again, reoperation. This is an X-ray of a patient I took care of in the National Heart Hospital. And when he was a youngster, his heart size was happy. 10 years later, with his mustard repair, he's in heart failure with severe right ventricular enlargement and severe tricuspid regurgitation. And here's his photo as a baby at the Hospital for Sick Children in Great Ormond Street. You see the primitive equipment. And here was a picture of him as a young man of 23. And you can see he's rather battle-scarred. And here's his latest scar for his pacemaker. He had religious reasons for declining a transplant, and so we had very little chance to help him. And what we thought we might do, as an only hope, is to see if we could switch his great arteries back to the normal connections. That's something that's been reported in young people. And in order to do that, you have to retrain the left ventricle. So you band the pulmonary artery to hope that the left ventricle will hypertrophy, wait for 6 months, and then reconnect the arteries to their proper ventricles. And we did that in him, and you can see the little scar here from the lateral thoracotomy where we banded his pulmonary artery. Unfortunately, as we have all learned subsequently, when you're 23, this doesn't work. The banding will not retrain the left ventricle, and he died about 3 months after this photo was taken. And I mentioned this challenge of reoperation and the Blalock-Taussig shunt, patients who've been palliated, who come back for definitive repair. This was, can you just imagine seeing a blue baby turn pink on the table in the 1940s? Just incredible. One of my patients felt so good after his Blalock-Taussig shunt that he tattooed himself with this thing. This is supposed to be our surgeon. Our surgeon doesn't look like that. But the patient did feel well, so he called himself Dr. Feelgood, and his mother was appalled by this tattoo, as was I. My only small consolation was that my initials came before the surgeon. But he felt remarkably well after one Blalock-Taussig shunt. But of course, that's not the end of the story. And here you see a patient with a Blalock-Taussig with pulmonary atresia, and it's already stenotic, and he's losing his blood flow to the right upper part of his lung. These operations have complications. And my same patient who loved tattoos, after operation number 5, tattooed this ever-ready bunny, and still going and going and going. And indeed, after operation number 6, he tattooed a zipper on the end of his sternum, which was not so attractive. But it just shows how they have to face these operations and reoperations. And just imagine a life thinking about that as you move forward. In our clinic, this is the age of the patients that we see. People think maybe most of these adults are in their 20s or 30s, and these are our patients divided by decade. And you can see here, this is a good problem to have, that 65% of the patients that we see are over 40. 10% of them are over 70 years of age. That's a fantastic success story which we can surely celebrate. And of course, we have guidelines that we've all written, both American and Canadian and from Europe, and all of them say the same thing, that these patients should be seen regularly in special congenital heart disease centers. And yet we also know, this study from Canada where healthcare is free, that it's not happening, and that when they're not seen in centers, it has an impact on mortality. And so despite having written guidelines for 20 years, patients are not getting referred to special centers. Fewer than 1 in 3 are actively receiving care at a center, even in Canada where the healthcare is free. We surely have more work to do. The Adult Congenital Heart Association, the patient group, has shared a lot of insights, and they have a message board, and as you're probably aware, they have thousands of members, with many of them have complex heart disease, and health professionals are also encouraged to visit, so I often go in and see what folks are saying very frequently, and it gives us, I think, a lot of insight and a window into the patient perspective. And it's a fantastic resource for patients. It's supervised. It's focused on patient sharing and support. Medical advice generally is banned or deleted, but we can see what patients are asking. And this is what the patients themselves say. How long do people with my defect usually live? What kills people with my defect? I'm choosing between X and Y medical treatment. Which is better? Where should I get care? Of course, there's a broad spectrum of patients. There are those who are at the early end asymptomatic. They may have simple defects. You'd never know if you looked at them they had heart disease. Sometimes they've been very well repaired. There are others who are diagnosed as an adult. Some of those may be partially or completely repaired. And then there are those very often cyanotic who you know right away are very disabled with complex heart disease, and it's very easy to see that they're fragile. And it's a broad spectrum of patient care with a wide range of experiences, but there are these 3 broad groups. They surely have challenges. Sometimes they're accused of being in denial from providers. They would say you can't be in denial about what you don't know. Many of these patients, again, believe themselves to be fixed, and they think their hearts are normal. And many report that the message they heard from pediatric cardiology was, don't worry, you're normal, go live your life. And they do this with gusto, as did Max, I understand, with the help of both his parents. And they would say denial is only an issue for those who have information and avoid care. They are not in denial. And they may have a rude awakening. They may first learn of ongoing risks when a new problem occurs, and they're often very surprised and angry. Why didn't anyone tell me this might happen? They told me that was my last surgery. And when I asked about problems, I was told, don't worry, you'll be fine. Medical providers often don't understand this response, and they say, but you knew you had this. You're lucky to have lived this long. Patients at that time are usually feeling many things, but lucky is not high on the list when you're facing another heart operation. The group who've been palliated, they may not be referred for repair because my doctor says if it ain't broke, why fix it? And this from a Blalock-Taussig shunt patient. They said, never let anyone else operate on your heart because you're in perfect balance. Often they see the lack of additional operations as a good thing. You should avoid more surgeries. And although significantly impaired, they may see themselves as doing fine because after all, they've never known what normal is. I'm fine, I just rest at the landings. My doctor says, I'm not that blue. When revised and repaired, if they can be, they're often very surprised by the results. I had no idea how good I could feel. Many were told, they would not live past 5 or 10, and some report a certain satisfaction from attending the funeral of a pediatric cardiologist who confidently predicted their early demise. Those that are visibly disabled sometimes say, "I wish I could have ridden a bike." Simple things. They manage teasing and social isolation, often with humor. I'm a member of the Smurf Club. And they just get on with life with extraordinary courage. Those that are unrepaired may have been told, "There's nothing more we can do for you," when the physician means there are no curative surgeries, but the patient hears, "You have no treatment options." And they may stop seeking care or accept perfunctory care when they sort of accept what they see as their lot. And so they may not receive care that's focused on maximizing the quality of life and symptom control. And they face, as I mentioned, extraordinary ignorance in the healthcare system, especially in the emergency room. I explained I was born long before they did switches. They told me that's impossible because transposition is fatal unless the arteries are switched back to their normal positions. These are actual quotes from patients. In the ER, a resident said, "What the hell is a mustard?" I said, "It's a condiment people put on hot dogs and hamburgers." I hate the ER more than anything. They have no idea what they're doing, and having to explain everything when I can't breathe drives me nuts. And from a general surgeon, this was a few weeks ago, my patient was facing major abdominal surgery, and he'd said to her, "I don't know anything about tetralogy of Fallot, but frankly, it doesn't bother me." Yes, say a prayer. It's extraordinary. And yet patients report, despite these challenges, that there are gifts of congenital heart disease, gifts, resilience, compassion and empathy, a sense of what's important, and a sense of the value of life and our lives. And many patients see their heart defect as having been a positive force in their life. They actually did a poll on the website. Would you choose to not have a heart defect? I would think that would be obvious. Of course you would choose to not have a heart defect. But the answer from the patients was not so simple. Yes, but only if I could also have lived my life so far as a person with a heart defect. They want it both ways. It gave them insight. It taught them something. And they only want to live their life if they could see their life as well from the other perspective. My heart made me the man I am today. It helped me edit my friends. It guided my career choices. It chose my activities. It focused my priorities. Without my congenital heart disease, life may have been far less interesting and memories far less cherished. I like who I am and the people I've met along the way. I'm far less shallow and more empathetic than I would have been without congenital heart disease. I live in gratitude because I know some days are not so good. Life is far more precious knowing the alternatives that I've faced at times. And one of my favorites, one of the top 5 reasons why it's good to have a heart defect, you meet a better class of doctor. So, as we think about courage, is this a triumph? Absolutely. I think we must break out the champagne. If we look back over 60 years, there have been so many changes that have taken place that have given us this community of adult survivors. There's no doubt that these patients begin life with a bad birthmark. But as I've shared with you, a lot of time, money, and effort has been spent to secure their survival, and a lot of courage on the part of the surgeons, the cardiologists, and more importantly, the patients themselves, especially someone as wonderful as your son. So I would leave you with this thought. Those who overcome great challenges will be changed, and often in unexpected ways. For our struggles enter our lives as unwelcome guests, but they bring valuable gifts. And once the pain subsides, the gifts remain. These gifts are life's true treasures, bought at a great price, but cannot be acquired any other way. Thank you for the honor of being here.
There's really nothing to say after that. It was just a really awesome lecture and very apropos to honoring Max. Just wonderful. Are there questions? Anybody want to ask a question or make a statement? That's how I feel, too. It was really awesome to have you here today.
Thank you very much.
Thank you, Tony and Rena, for It's been a really wonderful day. I want to thank Rena and Tony again, thank Max's friends and family who have come and to support him and honor Tony and Rena. I'd also want to do a shout out, sort of in honor maybe of the UK and tea, and Max made tea. We have some ladies, the ladies of patients and friends of families with patients who used to do a tea every up on at the baby's hospital and on 6th Tower. They would bring tea cups and saucers, fine china, and make sandwiches and things and have tea for the families and bring them together, and the doctors with the patients. And they're here, some of them are here today, and I really want to thank you, and I know that they too have had a wonderful day with you here. So thanks everybody. If you can come up and chat with Carol. I think you have to, do you have some time that people can come? Excellent. Okay, so thank you again. It was just really wonderful.